My name is Casey. I am a nurse and a community lead here at Trusted Health. Trusted places nurses and travel assignments across all 50 states, but we have a lot of content on our blog, on our social accounts, as well as we do events like this. Tonight, I am very, very honored to say that we have partnered with the Wilderness Medical Society to bring you nursing in the wild, Snakebites. You can go to the next slide, Ben. There we go. So like I said, thank you so much for joining us. If you want to ask questions, please use the Q&A function in the chat section on the right-hand side. When you look over on the right-hand side, you're going to see it in the middle up at the top of the chat. Use that and you can upvote questions that you also want answered there. We are here to listen, learn, and connect and get the knowledge you need to care for snakebites in the wild. And for the snakebite jokes and puns, of course, too. We can't forget those. All right, next slide. So our agenda, we're going to talk about snake bites by the number, why we treat them, all about venom, how you recognize and assess envenomations, envenomation care, and anti-venom basics. And with that, I would love to introduce our esteemed hosts for tonight and speakers, Dr. Abo and Jordan Benjamin. So Ben, I'll let you take it from here.
Sounds good. Thank you very much. Just a caveat, if I do look down, it's because my pup is dead in the corner, but my name is Ben Abo. I'm an EMS emergency physician and toxinologist. I am here also a fellow of the Wilderness Medical Society, which Jordan and my co-speaker is also, and we are the co-founders of the Asclepius Snakebite Foundation. Currently getting a lot of experience doing other things and really happy to be here on behalf of Trusted Health and the Wilderness Medical Society and of course Asclepius. Jordan?
Yeah, no, great to be here. We're very excited. It's a privilege. This is something that we're both really passionate about. It's also an area where I think it's so under taught in education at all levels, all medical education levels, that really I think hopefully in this hour you'll walk away probably knowing more than 99% of your colleagues and really being able to make a pretty significant difference for these patients. So
yeah, there's a lot to be learned. But we're definitely gonna get you there and point you in the right direction too. And so you understand kind of where we're coming from. A couple of years ago at Venom Week, which is a conference that Jordan and I met at with a bunch of specialists from around the world get together. We did start our Asclepius Snakebite Foundation, which for the herper nerds out there, Asclepius is the snake on the rod for our medical symbol. But we are taking an interdisciplinary approach to reverse the vicious cycle of snake bites, and you're going to see why. But that includes physicians, paramedics, venomologists, researchers, herpetologists, public health, and the whole point is to really do what and get people to help others, which is what we're all here talking about. A few years ago, just finally, the WHO said that one of the neglected tropical diseases in the world is snakebite envenomation. And they were trying to come up with specifically new strategies to prevent them from happening and to control them and to treat them. And that's where you come in and the Asclepius Snakebite Foundation comes in. And with that, it's, globally we'll talk about first and then bring it back to the United States. But Jordan will tell us kind of if you look at things, the envenomations globally by the numbers.
Yeah, so, quick overview on snakes, first of all. You got 3,000 snakes worldwide, roughly. And, they're finding new snakes a couple times a year. But I think we have a pretty good handle on most of the clinically relevant ones. So out of those, we have 600 we would consider venomous in a medically significant way, which means obviously they can cause some degree of symptoms. And then less than 200 of those are actually going to be deadly. And the vast majority of deaths are probably caused by about 50 of those. Globally, we think there's probably about 5 million bites a year, about 2.5 million resulting in envenomations. So there's a distinction there. You can have dry bites where a snake will bite defensively and not actually inject venom, and that's typically about 25 to 50% of the time. And then we think there's at least around 138 to 400,000 deaths and permanent disabilities. Probably around 600,000 if you combine those and add them together. But it's probably 2 or 3 times higher, and some people say up to 5 times higher, because we really have no data from places like Central Africa, virtually the entirety of Central Africa, where we would assume that based on the snakes and the the habitat and the people and the number of bites around there, there's probably a massive amount of deaths. So I think we'll see that number going up sort of as we move forward.
Even in the United States, even in the United States, the numbers are probably grossly underestimated. Think about how you do your patient documentation, right? Patient care reports. Is it paper? Is it computerized? Then people come in and it's swollen up to their hips, and they're like, it's probably just from the trauma of the bite, and they miscalculate it. It's just like the whole drowning, dry drowning thing. Dry drowning doesn't exist. They're all drownings, cardiac arrest or not. And so it's really hard to see the numbers. So it really is probably a gross underestimate.
Yep.
But out of this, the numbers tell the stories. Jordan?
Oh, no. Yeah, so around 95% of these cases are in rural areas. And that's going to be, far from medical care in general. And less than 10% of them will get anti-venom. And also a lot of the anti-venom that is available in places like sub-Saharan Africa is poor quality. And there's fake anti-venoms that we've run into, knockoffs. There's anti-venoms for Asian snakes that are sold in Africa, which don't have any cross-neutralization. A lot of patients will go to the traditional healers. And I think that just going back to the dry bite concept for a minute, because it's important in the US as well, a lot of patients will use things like venom extractors, which we'll touch on. And dry bites, essentially, because some portion of patients will get better, patients tend to think that their traditional medicine works because you could have someone who's bit by a cobra and gets better. And so it creates this unfortunate illusion that the traditional medicine is very effective and contributes to the delays that make these even more difficult to treat. But as far as demographics worldwide, it's mostly young, mostly men, mostly living in impoverished areas, doing agriculture, and bitten on the feet or hands, which are often permanently disabling.
And even in the United States, we talk about, as Jordan mentions, globally traditional medicine. We think of like shaman and Raymond kind of thing, really tribal leaders and stuff. There's a lot of traditional medicine and things that we've learned, and Florida man taught me this, or this guy taught me that, or he's a wilderness expert. And there's a lot of things that are passed down, and we even see that here. In the past 2 days, I've treated 3 snake bites here in Florida, and every single one of them actually included traditional healing, or I heard this, or I just took some Benadryl, or I tried to use venom extractor. So that stuff happens here as well. Overall, we're talking about, when you piece those numbers together, what Jordan was talking about, globally, there's over 600,000 people per year that are either killed or maimed or disabled. And depending on how you look, less than 5% receive any kind of anti-venom. In the United States, however, it's about 9,000-ish envenomations, and we're only talking about 5 deaths per year. So that's very different from kind of what's going on elsewhere. And you're like, well, why? What's the point, right? And why are we worried so much about, in the developed country, why are we talking about, if there's only a couple deaths, what we're trying to fight? And before I get into really quickly explaining that, I do want to point out globally another case of where luckily someone didn't die or get the point to, and this is a case that Jordan had in Africa.
Yeah, so this young boy here was bitten 3 days earlier. He's bitten on the foot by a carpet viper.
This is in Benin, right?
Yeah, in Benin. Yep, causes a bleeding syndrome. He'd gone to the healer. So he's bit on the foot, and basically over 3 days, he went into a full-blown DIC syndrome, and he scratched a little rash next to his eye, broke the capillaries. And it's a good example of just what happens with these patients. They're essentially fully anticoagulated, and then another component of the venom starts poking holes in the peripheral blood vessels. So, pretty dramatic presentation, but we like to use this case because it really illustrates the power of antivenom. And you can literally save patients, up to the moments before death with antivenom. We'll give some examples of that. But it is one of those sort of miracle treatments. I think one of the few cases in medicine where you can absolutely pull someone back and send them home in pretty amazing condition.
Yeah, really, really can make a difference, and we'll highlight that. So, and it's kind of crazy to think that less than 5% ever get the chance of getting antivenom. In the United States, a lot more should be getting antivenom, but they don't. And, even though that, we only have about 5 to 6 deaths per year, and every single one of those are people that didn't get treatment. Either they didn't go for treatment or treatment was withheld from them, which quite honestly is negligent. So if only 5 people die per year, then you're saying to yourself, why are they treating it? Well, the fact of the matter is, there we go. Okay, sorry, it changed order on me. Sorry, I thought. I'm getting the anti-venom to the places. Apologize for that. So why treat the snake bites? The snake bites cause permanent pain. They cause permanent disfigurement, permanent disability, and permanent death. Right? So these are people's livelihoods that are going on here. These are people's ability to do things, to work. That child, even if that child had survived, would they be able to work? Would they be able to walk and do things? And you're going to see from these cases that we have here some pretty gruesome effects. And you're not quite sure kind of like how that is, that it caused the permanent pain, permanent disfigurement. There won't be much question afterwards when I show you this. Now, how is it doing it in some of these things? There's a plethora of ways, and we'll talk about how venom works. But it can absolutely end up leading to renal failure, cause psych issues, myocardial damage, infections down the road. The initial bite is not infected. Cause autonomic dysfunction, disability, maternal mortality, fetal mortality if mom that's pregnant is bit, leads to amputations and limb loss or loss of function, blindness, a whole lot more. So overall, like I said, and Jordan was alluding to, we're saving lives and we're saving livelihood. And that's within the United States and elsewhere. Now, statistically, and I'll go back because they kind of switched, there's different types of snakes and different types of species. And every single one of you have probably learned, oh, hey, there's 2 types of venom, 2 types of snake. There's heme toxic snakes, like the vipers, and there are neurotoxins like the elapids. And it's not quite like that. Now, in the United States, 99% of envenomations are by pit vipers or Crotalidae. So this includes your rattlesnakes, which is anything that twerks to warn you, Eastern Diamondback, Western Diamondback, all those kinds of things, and also the copperhead and water moccasin, which are also pit vipers, but they don't have the rattle to warn you, right? So that's 99% for the United States. And the 1% is coral or a lapid. Now, there's a small percentage where we get exotic. We'll kind of talk about that briefly. But these are our stats. As opposed to globally, we're talking about 95% being pit vipers and the 5% being lapids or other. And elapids globally include coral again, but of course include also our mambas and our cobras and things like that. Now, a lot of people tend to talk about the pit vipers being the heme toxins, and that's really it. We don't talk about anything else, but you're going to see that we really get into different toxidromes and things throughout it. So there are a lot of combinations, and that's why we really, again, and I'd like to repeat and reiterate, permanent pain, permanent disfigurement, permanent disability on top of fighting permanent death. So how do envenomations? Basically, I like diagrams. I'm a very pictorial person, not to mention picturesque with hair like this, you gotta say it. But how envenomations happen, I think of like a Venn diagram, right? So you have the human world. We're doing human stuff, whether we're doing stuff in our own yard or prepping for a storm or cleaning up after, or we're just doing field work, right? So that's the red, the everyday activities. Then snakes tend to do their snake stuff. They are not hunting us. They do not want to use their venom on us. It's all purely defensive. But when snake factors come into play and human factors come into play and they overlap, our worlds collide, and that's where you get envenomation. And that's what ends up happening when the worlds collide. So there are different factors that lead into how severe an envenomation is. Of course, whether there's any venom at play or not is a big one. And then if it's a dry bite, which Jordan already mentioned about. But then once you have an envenomation and venom is injected, there are different factors that determine the severity of it. And there are the human factors and there are snake factors. Various things in there you can see on the left here, the quantity, right? So how much of this toxic substance was injected into the person? And of course, how much of it, as well as the composition. And we're about to get into that. What are the toxins in that venom? It's not just heme toxins and neurotoxins. I keep saying that. We're going to dispel that. And then the human factors include our own human biology. What's the bite circumstances? Where was it bit? Did we get two fangs? Was there much injected into us? Did it actually get into our skin? And then first aid, treatment quality, delays, and definitive care. Now, out of these things, there's really only a few that we can really make a difference. And that's why we really want to dispel some of these myths and talk about it here today, right? So the treatment quality, that's the first aid that's done, whether correct or incorrect, and then how well it was done. Definitive care, which is the amount of time, and I already saw a great question about living in Arizona, and we're going to get to that. Getting time to definitive care, it doesn't have to be a level 1 trauma center. This is not a surgical disease, it's a traumatic disease, but not a surgical disease. And then is there a delay in anything? A delay in care, a delay in anti-venom, a delay in proper first aid care. So there are factors that we can change, and there are factors that we can't once the bite has happened. So let's get into the venom. This is something that I've gotten very interested in from a haphazard way. Jordan's been interested in snakes and has been a herpetologist carrying snakes and stuff for a number of years. For me, I used to have a phobia of snakes, but when I saw what it was doing to people and to patients and the just miseducation out there, I really started studying venom and the education to get people the proper care. We're not going to make you all venom scientists or venom specialists, but have a healthy respect for it. We're going to dive into it. So what is venom and how does it work? I like to think of venom as a cocktail of toxins, right? It's not just hemotoxin, neurotoxins. There are a lot of different effects. Now, it comes down to a lot of different toxidromes, and all those toxins and ingredients do different things. They work together to make other things happen, right? But what it all comes down to is we have 3 main toxidromes, 3.5, as Jordan and I recently been talking about, that we worry about. There is the hemotoxic, there's the neurotoxic, and the cytotoxic, right? And we're going to break down this little set of triangles here, which is a graphic from the CPGs that Jordan will discuss that we did. But these toxidromes are interesting, and they're not all the same. Even if the heme toxins, right? Is it using up all your platelets, or is it causing bleeding, like that child that we saw? Or even if it is causing bleeding, how? Is it actually maybe causing coagulation, and then you essentially go into DIC? Or is it breaking down your endothelial cells? Even how it does it with the heme toxic, it does it in a variety of different ways. And of course, there is no 100% pure hemotoxic, 100% pure neurotoxic thing. You're going to get combinations therein.
Yeah. I think that's one of the most important things we want you guys to take away from this is, you got 3 syndromes, you got 3 major signs and symptoms of each, but don't expect to get a clean cut on this, right? When you're assessing, you should always be assessing for all 3 of these, knowing that you could get some combination of, A and B or C and A, or, or all 3 of them, really depending on what's happening there. And then just to speak to the cocktail of toxins piece. Oh, actually, sorry, go ahead, Ben.
Yeah, no, go ahead. Well, yeah, one of us, go for it.
Yeah, so I was going to say, so even a single rattlesnake can have over 100 different bioactive compounds in their venom. And that includes vasodilators that open up those vessels to help it circulate better, things that punch holes in the blood vessels to get out to the tissue. So Ben and I like to, we always talk about this as like a symphony effect, right? You've got different groups of instruments that are playing different sections, and then they come together, and so no 2 bites are ever going to really be the same.
That's even if it's the same species. If Jordan and I are twin snakes, right? Except of course I'm the snake with the better hair and better puns, but we're from the same litter. There's a lot of factors that go into the toxins that are in our venom, and you can scientifically evaluate our toxins in our venom, and they can be different. Geography, time of year, our prey, altitude, temperature, the Mets' last baseball game, whatever. There are a lot of different factors that go into it. So I really like, we talk about all the time the symphony, because I really love music, and it's a great way to do it because it works together, but also the cocktail of toxins, right? A toxin is anything that's affecting the body in some way, for better or for worse. In fact, medicines or toxins, they just were controlling to a certain extent the amount they do. So even if you order a special margarita, what ingredients are in there? If you order martini, what ingredients are in there? If you order a Long Island iced tea, is it the 5 different liqueurs that are in there that mix it up to give you the taste, or is it the cheap kind of sugary thing? You never really know what you're going to get, the different cocktail in there, and it can keep changing. And whatever that cocktail is, once it gets into you, it's going to have its effect on its body. This is actually a picture after we were filming Kings of Pain from one of the guys that would get envenomated by different things, and he was complaining of brain freeze. So that cocktail that he had its effect on his body because of different factors and the ingredients and the temperature and things like that. And can we fight it? Yes, we can. We have the cure for it. And the one cure for venom is, of course, what, Jordan?
Anti-venom.
Anti-venom.
Yep. And just, there was a fascinating case recently that really illustrates this, where 2 people actually got bit by the same rattlesnake and had completely different effects. So there's a lot of mystery still in snakebite, which is part of why we're so drawn to it. You just need to sort of expect the unexpected, but use the syndromic approach we give you. So.
Seriously. All right. So there's this guy with, some great puns and a great dachshund that likes to say there is no always. That'd be me. 2021, you heard it here first. And you're going to hear this over and over, right? So this is from, and I want Jordan to kind of tease away because he was the lead on this, but a number of specialists, we came together and made the new guidelines for envenomation care globally for the military based on where you're at, and tried to make it as simple as possible. We tried to make it so easy that a physician can get it right. Jordan?
Yeah, so it's definitely a good resource. It's probably the most comprehensive sort of global take, especially for those of you doing travel nursing. You can print this off, go to the Joint Trauma System, or just look up Snakebite CPGs. This will come up, and you can print off the main section, which is a general approach, and then grab whatever section for your region that you're going to and staple that on there, and it will give you pretty much everything you need to know. But the key point is, again, remember you got 3 syndromes, right? 3.5, which we'll talk about, as Ben said, but 3 major signs and symptoms of each. And you can assess this in a certain way we'll go over. But basically, you will always see at least one of these elements in a significant snake bite. And so to address the question about can you tell if it's a dry bite, you can, because a dry bite won't progressively get worse, and a snake bite with an envenomation will.
Beautiful. Let me click here. So, recognizing envenomations and their effects. As I said, a number of factors go into it, but in general, you have local effects, you have systemic effects, and you can have lab effects. And so that's why there's certain labs that we're going to try and pull or look at. And again, there is no always. So I hear a lot of times, I just heard it this morning where a nurse, a physician were like, well, there isn't much swelling, where it doesn't have to. We'll talk about it, but possibilities that are there, and you're going to see this in picture form in a moment. There's swelling, pain, tenderness, which are different, right? What's the difference between pain and tenderness? And don't just tell me it's spelling. It's pain is what you feel. Tenderness is pain that's elicited. So when I'm touching, ouch, it hurts. We'll get into this. There could be erythema. There might not. There could be necrosis, blood blisters, different things like that. All these local effects, but the venom progresses. The local effects all progress lymphatically and progressively, right? Systemically, you can have things like altered mental status, seizures, unresponsiveness, nausea, vomiting. And folks, if you're retching and vomiting, nauseated, you just don't have anything left in your stomach, that's still retching, right? So I had a case at the University of Florida where they're like, well, is he vomiting? No, and it's because the kid's just sitting there retching. There's nothing left to vomit after an hour, but all the Zofran and everything wasn't working. That's a systemic effect. They're not bit in the stomach, but they're having these systemic effects. Hypotension, autonomic dysfunction, apnea, paralysis, and usually it starts central, like the ptosis, like in the triangle showed, and bleeding in other places. We're going to show you this. So the site, I get bit on the hand, but I'm bleeding from IV sites or in the gums. We're going to show you this. And then, of course, labs, right? There are different ways that we can cause bleeding or coagulopathies, things like that. So we're looking at things like the CBC, especially the platelets. We're looking at our coags, PT and INR, or we're doing WBCT, which we're going to touch upon in a bit if you don't know what that is. Fibrinogen, BMP, and plus or minus the CK, depending on the delay, to see if we need to prevent rhabdomyolysis. So those are the labs you're looking for. These are a lot of the things that you're looking for: local, systemic, lab abnormalities. But again, there is no always. So I haven't had any volunteers to have a pit viper bite them so I can get a picture of it. Usually they'll bite and they'll let go. But of course you're gonna have the potential cut and the fang marks, or one fang and a drag, like a bite that I had last night. I do need to say to you, the swelling from the trauma of a bite, there are a lot of nurses and physicians that'll look at it and be like, well, you know, it's probably not the venom, it's the trauma of the bite, it's swelling. If you make fun of my dog or my hair, and I'm upset with you, and I take a 21 gauge needle, Jordan, would you say about 21 gauge about some of the things? Yeah. Mm-hmm. A 21 gauge needle with no venom, no toxins in it, and I stab you in the arm, is your arm going to progressively swell? No. Is it going to progressively continue to bleed? No. Is it going to continue to hurt for 15 plus minutes afterwards? No. So if you have that swelling, it's not like a dog bite or a large cat or something like that, where yes, there's major trauma to it. We're talking about a 21 gauge needle that goes in and comes out, right? Even a cat bite doesn't progress that much like venom does. So if you'll see the fang marks and then see what else is around it. You may or may not have the blood blisters and blebs. You may or may not have the redness, the spread. You can see in the picture on the right the two thumbs with the swelling, and you also see some of the ecchymosis, which is on the opposite side from where the blood was, or the bite was. But you might not see all of them, right?
And I think what, what Ben said is it's a great point. So just going to that needle, analogy, I think just think about if you gave someone a sub-Q injection and they are experiencing things that aren't consistent with that, that's probably the venom. It's sort of a simple qualitative way to just say, is this venom or not? Because again, they won't always present the same way.
So here I have one of my toddlers here that was bit on the hand. If you look close, you see swelling, you see ecchymosis, and they did a line of just the swelling, but up higher was actually a lot of pain and tenderness. It locally went up. The two hands, different sizes. Where's the pain progressing? And the picture on the right was a bite that we had in Africa, where you can see the progression and you see some of those blebs and you can appreciate some of the swelling there. But again, there is no always. I showed you that picture, the thumbs there. The picture on the right here is one where there was ecchymosis and swelling, and there was a significant delay for her to get out of the forest to a hospital. They said, well, we're going to transfer up to the university. They didn't give anti-venom, and things continued to spread up. And you can see on here the timeline, and there's a T for tenderness, there's an S for skin changes, and you can just see that progression, the ecchymosis, the swelling in some parts. But I don't see any erythema. I don't see any crazy bleeding. Why? Because there is no always. Then, of course, this gentleman, Jordan, you want to tell about our guy in Guinea?
Yeah. So this gentleman was bitten by a rhinoceros viper, which is quite a dangerous, very large viper, one of the largest ones in the world as far as longest fangs in the world, largest venom yields. He was bitten 18 hours earlier, and here you can see, if we were going to go to our syndromes, we have two things, right? We have cytotoxic, we have pain, swelling. You can't see the pain, obviously, but it's pretty clear he's probably hurting. And we have tissue destruction there with the blistering. And then we also have persistent local bleeding. So again, bleeding that sticks around longer than you'd get from an IM injection or a sub-Q injection, that's going to be abnormal. So unless they sliced it open with a knife, in which case think about what's proportional. But here, 18 hours later, he arrives. He's got a very significant progression here, a lot of local tissue destruction, and symptoms moving up the limb there as well. He had swelling all the way up to his hip, and he actually had edema that had gone into the abdomen and then down into the scrotum as well. So we'll go right up those fascial planes. And you can see effects pretty far away from the bite site.
We're going to bring this gentleman up a little bit later, you're going to see. But, you know, that progression of those local effects, when you look closely, there was no erythema, there was no contusions, but you had the different things. And of course, you know, the effects itself and the local effects, the cytotoxic causing the swelling or whatever else, can cause a number of issues. These are 2 cases in Florida, one of which was mine. You know, we have a kid that had kept a water moccasin, which is a pit viper, under his bed in a pillowcase, and he went to kiss it. No, I'm not making this up. And he got bit on the face, and that swelling. This really talks about an airway concern, right? This is a pit viper airway concern. And then you have a male that was bit on the tongue by a juvenile eastern diamondback, right? That's swelling. And this picture is from within 45 minutes of the envenomation. They did not try to nasally intubate. Look how big that tongue was. It was a very difficult intubation. He ended up needing a surgical airway as things kept going, and the trauma directly to the tongue. But look in the nose. What do you notice, right? He's already systemically bleeding. In fact, this guy's first set of labs, he had platelets of 7. For those of you in different countries, you know, and depending on the ratio, what things you're doing, for labs, you know, our platelets really shouldn't be below 110. Like they shouldn't, if you're a normal, healthy person. And he had 7. He basically had a platelet or 1,000 platelets for every dwarf that hangs out at Snow White. But you can see the significant airway concerns, which is a little bit different than neuro airway concerns, which we're going to show you in a moment. So here I have somebody that was bit by an eastern diamondback. You can see in the picture on the right where, yes, there's the swelling, there's ecchymosis, there's the bleeding blebs on the finger. If he didn't happen to have be unresponsive, he'd probably tell you that the pain was going a lot further up. Now look at the picture on the right. Okay, this is the same guy taken basically the same time. And first I want to point out here you see, obviously, like I just said, the hand ecchymotic and everything like that. But what they did was they noted where the swelling was, and they put a line, and they're like, well, it's not progressing up any further. I didn't trust it, but just because of the format on this, but I have video of beyond this, up in the further region, there was actually fasciculations going on. It was acting like we gave him succinylcholine. And the guy didn't even have any paralytics or anything on board. It was purely the toxins in this hemotoxic rattlesnake, right? We have the cyto effects that you can see there. We have systemic effects, and we have neuro effects from the fasciculations. So again, there is no always, and it's not just skin changes that you need to look for in the tenderness. All right, so let's get into the care of it as we're already about halfway through and give you some tips. Number one big point that we want you to take home is you need to recognize envenomation potential. This is outside the snakebite clinic that we were helping set up in Guinea. Probably you can't see it, other than you see the dog and I, that random wild dog that was following us is great. But you know, in this picture, probably several hundred snakes that we were out looking for, mambas and cobras and things like that. I live in Florida. You know, I didn't look fully, but I don't know how many of you live in New Zealand. No venomous snakes, naturally. Ireland, for the US, Alaska, Maine, they don't have any venomous snakes that live there, but everywhere else you got venomous snakes all over, right? So recognize the potential and remember that denial is not just a river in Egypt. I need you to stay safe. I do not need you to kill the snake. I don't need the head to identify it. I don't need you to get close. If you're close enough to see the elliptical eyes that can still dilate, you are just way too close, right? This is a Ziploc bag is not going to help. This is a snake in Texas. This is a venomous snake, a pit viper, and it was put in a Ziploc bag, and then they're like, oh wait, this thing's still alive, right? I definitely don't need you having nurses send it up in the tube system. That may have happened at one of my hospitals when I was away. Yeah, so there's a lot of potential. I need you to stay safe. I don't need you to do it. Even if you're outside the United States, we have the CPG set up so you can recognize the syndrome and figure out how to treat it based on the anti-venoms that we are going to get into a little bit.
Yeah, and this is a huge point. So you don't need to know the snake species to treat the bite. It help? So it helps Ben and I because we know more specifically the sort of oddball effects to expect from snake A or B. But we can always identify through that syndrome and treat with an appropriate antivenom without knowing the snake. And actually, a lot of bites happen from trying to kill the snake. I've had a 3-person MCI from a mamba who they threw a rock at once. So you just better let the snake go. Let us figure it out from the symptoms, or figure it out from the symptoms, as you'll learn here.
You want to make sure that they know what an MCI is?
Oh yeah, multiple casualty incident. Yeah, we had 3 patients bitten by the same mamba. They all crowded into a house. Someone threw a rock at it, bit 3 people on the way out. So.
Yeah. I did notice something that slide was hidden that I want to get back to after we get through these numbers. We'll do it. So step 3 is like Jordan likes to call ABCIV. So start with your basics and your assessment for the patient. Get your ABCs, your airway, your breathing, circulation, make sure their vital signs are stable. Get IV access because that's how we're going to give the antivenom and any fluids or anything else. Assess for any signs of envenomation. Again, this is looking both locally and systemic. Jordan, do you want to say anything else on that?
Yeah, so a simple way you guys can do this is for local things, think bottom up. So you're going to go distal to proximal. If they're bit on the hand, check from the hand up to the shoulder. If they're bit on the foot, go from the foot to the hip. You're looking for, again, from each of those triads, you're looking for the local effects. So for cytotoxic, it will be pain, swelling, and blistering. For hemotoxic, it will be persistent local bleeding, and then you'll see bruising, and then you could even see old cuts and wounds start to bleed or petechial hemorrhage under the skin. And then for neuro, it's sort of variable. You might see fasciculations locally, for instance, is a common thing. Then for central, you're going to jump up to the head and move right down. So bottom up, top down. In the head, all your neurobites are going to start with essentially the definitive sign is ptosis, right? So they get bilateral paralysis and drooping of the eyelids here. Tell them to follow your finger, look up, or don't look up, and they can't do it. They start to sort of droop like this. It then moves down. They get paralysis of the throat, the tongue, start to pool saliva. It moves down to the diaphragm, and they're paralyzed. And for the bleeding syndrome, what we see is that they will begin to bleed from the gingiva, and that's pretty much the first sign of a systemic bleeding syndrome. After that, they'll get hematemesis or blood in the stool, and then finally, it sort of progresses to either bleeding somewhere with too much space, like the abdomen, or too little space, like the brain. But it's a fairly linear progression. Check the CPGs for reference on that. But you can just sort of remember those 3 triads, again, assess bottom up, so distal to proximal, look for the local signs, and then go top down. And you're going to want to reassess this periodically because they can change, right? So you could have just cyto, and 15 minutes later, all of a sudden, they're going full-blown neuro on you.
So let me get back into here since Jordan was just talking about it, and this is, I guess I missed the slide that was in there. This is a great example of taking that top-down approach, and this is really important. This is a gentleman who was bit by a very large rattlesnake that he went to 15 minutes to the local hospital that was rural, and I know that one of the nurses that treated this patient with me is on here. Hi, Kristen. And basically, he goes to the triage nurse and says, I got bit by a rattlesnake. The nurse looked at him, looked at the hand, and said, go ahead and sit down and triage. He goes to, instead of sitting down, he goes to the bathroom, close the door, and it immediately syncopizes. Now, he got to me after they intubated him and he was on pressors. In this picture, you can see the gross bleeding in the hematuria. His heart rate was 160 and ischemic. He was bit on the hand and barely any wounds, but he was on 3 pressors and his blood pressure with an A-line was still only 50/30. And I looked very carefully, you could see the picture there of his hand. You barely see any swelling. And it wasn't until the next day where he even had any swelling there, right? So you don't have always, and you need to do the full approach, look for the systemic and consider that there's a potential for it to be there, right? This picture on the left is from I believe it was a mamba bite. Correct me if I'm wrong. Black mamba in Africa. But all of a sudden, pretty quickly, she starts having that central paralysis like Jordan was talking about, the ptosis where you can't keep the eyes open, foaming at the mouth, and this becomes a very difficult airway very quickly, even though there isn't swelling or anything like that. A very different time progression compared to, this is a kid that we had in Florida that was bit by a coral snake, and there was a delay in getting him anti-venom, and it wasn't until hour 11 and a half where suddenly he had these signs right here. You can see the ptosis, you can see the muscles because they're trying to open their eyes really hard. So you see the muscles here and the central paralysis, and they actually complain also of double vision. And how can you assess the double vision or what causes it? If you do your extraocular motor look for your neuro checks, at one point the eye was partially paralyzed when he would look over. And he actually didn't get over that paralysis of the eyes for 7 months. But time can be very different for these things. And of course, with that full approach, this is a gentleman in Guyana who was bit on the foot, but he was very thankful and stuff, but he had gingival bleeding and he kept spitting into that cup and he was peeing blood. So it can be anywhere, and there was no swelling of his foot for that either. So you do your assessments for any signs, local and systemically. Then you remove your anything constricting, any jewelry, any clothing like that. So there is no tourniquets whatsoever. Get it all removed, and that could be clothing too. Next, you want to note the time and the location of the site of the bite. So if I'm bit on the hand and there's some fang marks, circle it, note the time, little animation here that we're going to kind of go through. The leading edge, and this especially is with pit vipers, I like the leading edge of skin changes for an S, P for pain, and T for tenderness. So there's skin changes about halfway up the hand, so I put a line with the time for S. It hurts up past the wrist, so I put a time there with the P. And then I use a T for the tenderness, so I walk the finger down, and then it hurts there. Okay, do that. You're doing this every 10 to 15 minutes. So you can see what the progression is, and this is one of the vital signs of pain. You see in some of our pictures where we just marked it instead of the line for skin, we put a dotted line or a dashed line. You could do any sort of change colors, I don't care, but you want to see the progression, note the difference between the pain, the swelling, and the tenderness. This is an eastern diamondback bite that I had here in Florida, and the friend did the right thing. He immediately marked the line and he put the bite site. He had seen one of our lectures and knows some of our Venom 1 guys, but he marked the time. And then when he got to the hospital to see me, I put a line with the S, the skin changes, and I put the time there. And you could see where the skin changes were kind of going up. You see the S there, 210, 305. That you see the P all the way up near the top and the tenderness as it continued to progress. But then in this case, we got him anti-venom right away. He happened to be a case that had to be rescued by helicopter, and so we were already mixing the anti-venom before he got to me. So as soon as he hit the ER, I did my assessment. I started giving him anti-venom, and the tenderness regressed. The pain regressed. So that's what the dotted line is there, and that's why the time lower is actually later.
Yeah, one thing that Ben likes to say that I think is a great way to remember this is snakes don't have meters, and that's why this is so important. What we're doing here with this trending is we need to give an amount of anti-venom that is proportional to the amount of venom to neutralize that. So, but we can't figure that out through a lab test, right? It's all qualitative. So how do you know that? You know it because the pain starts to regress. The swelling stops progressing. It doesn't regress right away, but it won't be getting worse. The neurosigns will stop progressing and eventually recede. And then any persistent bleeding needs to stop. Coagulopathy can persist for hours after, but any bleeding from the gums, from the site, it's like turning off a spigot when you hit the right dose. So okay. Trending is absolutely critical to dosing the treatment here.
So a lot of you have heard about, demobilize it, things. Yes, you want to stop, minimize movement as much as possible, and then you actually also want to elevate it. Elevate it. This is not like they have a sprained ankle, so you just kind of prop it up a little bit. If the hand is bit, I want the fingers above the wrist, higher than the elbow, higher than the shoulder. If it's the foot, I've actually had people in the hospital in the ICU, and I just put their feet at the head of the bed. So if the back was up, their feet were up in the air. There are different ways. This is a way. I was actually at a freestanding ED. That's the picture on the left with the ortho sock to get it up, and it doesn't put any pressure in one spot. But I actually was able to cut the ortho sock and continue to do my assessments. Or this picture from Dr. Green, a child that was bit. The elevation is key as soon as possible, not just wait on it. And then after they get the treatment, then we could get it mobilized. But elevation is absolutely critical part of this. I'm sure somebody has already, if not they will, ask why is it so important? We don't want all that venom and toxins that spread lymphatically to concentrate in the extremity. If you can spread it out, it's not like a ticking time bomb where as soon as it gets to the heart, they're gonna die. It's lymphatically spread. So you really want to spread out because we have the cure. It's the anti-venom that is going to work and get to them. Don't forget about pain control, whether it's opiates, ketamine, Tylenol. There's a paper here in the corner that Dr. Brandehoff did based on our experiences in Guinea, which was great. And we talked about ketamine for pain control, where you can't really get opiates and things like that, or maybe you don't want Tylenol, but you're just not doing Toradol, you're not doing NSAIDs because of the theoretical risks of bleeding. In fact, they're not even going to get NSAIDs, especially if it's a pit viper bite, for a couple of weeks, right? So whatever it is, be comfortable with giving them pain medicine. It's not going to interfere with your assessment. This is a very painful disease process, right? And I talked about his paper. Perfect. So labs. Labs that you're going to pull are the CBC, a BMP, a set of coags, PTI&R, and your fibrinogen. Now, if there's a significant delay and there's already a lot of swelling or a lot of skin changes, I get also a CK to evaluate. And if it's elevated, I'm going to protect their kidneys by, of course, giving them plenty of fluids. So these are really important to draw. You're going to draw them as soon as possible. And especially with your Crofab, Antivip, or anything here in the United States, after you give the anti-venom, an hour later, we're going to check it again, and we tend to check labs a certain amount of times. That depends on the snake and your specialist. In the United States, we're doing it every 6 hours, and depending on what's going on with your specialists and where you're at, we might pull labs at different times elsewhere. Now, Jordan, what do you do if you don't have labs?
Yeah, so low resource area is super easy. You take a clean glass tube, it can be an old medicine ampule or whatever. Boil it, wash it out, make sure there's no residue. Take a couple mils of venous blood, put it in the glass tube. It has to be glass. Sit it upright and open at the bedside. Set a timer for 20 minutes. Do your assessment. 20 minutes later, pick it up, tip the tube. If the blood runs out of the tube, you have a coagulopathy. And if it sits there like a nice Jello shot in there, then you're good to go. You'll actually see that improve qualitatively during treatment.
Awesome. So then, of course, anti-venom. Choosing whether or not to, you have to be familiar and comfortable, but if you need to, carpe remedium, seize the cure, absolutely do it. So here actually is Jordan giving somebody, he was just bitten by a mamba, he's giving the anti-venom. I don't want you to be afraid of it. It's not going to explode. We can get you the right stuff depending on where you're at, right? So when you need to, you absolutely need to do it. Now in the United States, there are three all anti-venoms are basically antibodies are derived in some sort of animal, usually a horse, but there's one that's in Australia for us here. And then the antibodies we're injecting into you to give you passive immunity temporarily, right? So there are three that are FDA approved for pit viper envenomations. You have Crofab and Antivip. Crofab has been around since about 1999. Really on the market, and Antivip's one is a newer one. So those are for your pit viper envenomations. In fact, Antivip just got approval. It was only rattlesnakes and just got approval. We want to see what the papers show, but just got approval for all North American pit vipers. And then with the coral snake anti-venom, there's a specific monovalent one which we'll use for Florida, all envenomations, and then severe envenomations if it's a Texan coral. This is what we have for within the United States. These anti-venoms, they used to say that, oh, well, the cure is worse than the problem. No, it's not true. There's a very safe safety profile. In fact, looking at the numbers and the huge numbers they got for Crofab, is less than 5% of a severe reaction. And you know what that severe reaction usually is? Just a severe rash. So you give a little bit of Benadryl. Even if they have a severe reaction, we stop, for whatever reason, you stop the anti-venom, you treat the reaction, and then you go on. And we might even, we talk about in our lectures and our online stuff that we'll give you, Jordan has written about some of the pre-treatments that we'll, maybe if we get a chance, we'll talk about if you know that they're allergic. But by golly, you don't want to withhold pain. I'm allergic to horses, but by golly, if you refuse to give me a horse-derived anti-venom, that's negligence, right? Please know how to properly mix it, how to properly administer it, and don't do any of this sub-Q testing dose. I know that even some universities still do that. It's a waste of time. Just don't do it. Know how to put it in. This outside hospital had a bite, and they put 6 vials in the fluid here. They put 1 box, which has 2 vials in it. They put 1 box in each separate bag. No, just put all the anti-venom in 1 bag and then do that over an hour. All right, so know how to use it, how to do it, and we will guide you through it. There's specialists how to do it. If you don't quite get it, ask us. I'm always here for you. The venom teams are here for you. Others are there for you. If you have an exotic bite, you need to get the antivenom. You can't necessarily just call the zoos. You can try, but that's why we have different venom banks. This is Miami-Dade's venom bank. Over 1,500 vials of different things, 55 antivenoms. But different countries, we have specific ones, and they're ones that Jordan and I trust, or some that we don't. But we do it so you have broad coverage to be able to do it. And hospitals can't, in the United States, hospitals can't keep on stock these drugs because they are not FDA approved. But we have, I have a special permit or licensing from Customs, FDA, and the DEA or USDA, to import these. And so the zoos will have it and things like that, so that you can get it to there. And of course, you have to get it to there. And once you give the anti-venom, you need to assure that it's working and that you get control. You need to make sure you get it there. When you give, especially if you're giving Profab or out of it, you're treating in the United States, you need to make sure that any local effects is no longer progressing, like those vital signs. You need to have full resolution of any systemic changes. And if you have any lab abnormalities, they need to trend towards normal. And then you're going to assure the control with proper discharge instructions, followed with possibly blood work in 3 days and 7 days, and maybe afterwards. See this guy giving the thumbs up where he's stepping on a very swollen foot? This is the same guy that we showed you earlier that was bit, that had the swelling all the way up to the abdomen and down to the scrotum. That bloody foot that was super painful, and now he's able to step on it. So this was a great example of a case where we got him even after delay, which you try not to have, but we gave antivenom, we treated, and this guy is able to go back to work. That guy that had the 50/30 blood pressure on 3 pressors when he first came to me, and as we gave the anti-venom, the Profab was just kind of going in, and I turned to the nurse and I'm like, hey, Kay, turn off the pressors. And I know she's on here. I said, turn off the pressors. She said, oh, go down to what? I said, turn it off, unplug it. She's like, huh? And you literally could see as the anti-venom bag's going down, the blood pressure coming up and things getting better. You're saving lives, you're saving livelihood, right? Please be aware of bad, fake, dangerous care. The venom extractors, these are the no's as we wrap up and we answer questions. No tourniquets, no cutting, no sucking, no electrical shock, no venom extractors, no fasciotomies, no alcohol, no ice. The ice vasoconstricts, which concentrates. These actually are all proven to do more damage. But what I want you to do, systematically proven, know about the safety, you be safe, ABC IVs, evaluate and assess, remove anything constricting, elevate and immobilize as soon as possible, check labs or do your clotting stuff. Please give them pain control, mark the progression and do your ongoing assessments. Feel free to call any venom or tox specialist and use the anti-venom when indicated. Don't be afraid to, okay? It really is time to change how you think of antivenoms, where people are like worried about how dangerous it is and things. People say, well, it's really expensive. Well, it's a lot more expensive to pay for permanent pain and permanent disability, right? So change how you think. Antivenom for snakes is absolutely a safe and proven standard of care. You don't need to identify the snake necessarily. We can figure out based on the toxidromes how much and what to give, also geographically based on where you're at. So with that, you know, the little moral morsels take away, please know, dry bites do not progress. Proper first aid matters, and anti-venom is that cure, right? And those little first aid things are really important. Your assessment, you're the ones that are bedside more, whether it's bedside out in the wilderness or beyond. You got to look for those toxidromes. You need to look and monitor what's going on and stay systematic on how you're doing it, and understand that anti-venom is not worse. It's you know how to use it, know how to mix it, and it's okay to ask for help. All right. So I appreciate you joining us. Here's our contact information. I'm going to switch over to see with these last couple of minutes with some of these questions. I think Jordan, you can see the questions also, right? So we can we can go through and see. Steve had asked about living in Arizona, rattlesnake bites. You know, there you have what, 22 types of rattlesnakes. What's the timeline? It really all depends. The snakes don't have meters. As soon as possible. I will say that if you're further out in the wilderness, don't wait for signs of envenomation. Unless you're 150% sure that it's not a venomous snake, you better go to get checked out. And we're going to monitor you for a certain amount of time and assure that it truly is a dry bite, because I've seen bites not react at all until 6 hours later. It's a great question. In the bites where they're largely non-lethal, what are the comorbidities? It's all the same thing. The comorbidities, maybe you mean, Connor, in terms of their other health issues. If they're pregnant, I'm still treating. I'm more likely to treat. If it's a kid, are they on chemo? Are they on blood thinners? I need to treat and stop this venomous effect. And we're trying to stop that and get them mobile again. Has antivenom been used in other situations in the ICU since it reverses the DIC? Wendy, that's a good question. No. The DIC itself, you know, the antivenom is for this specific process. There are a lot of similarities where it's being studied, but you know, actually a lot of our medicines, you should know, actually comes from venom. Captopril is based on venom. Breast cancer treatment is based on copperhead venom. There's a lot of things that are based on it, but venom itself, we're not going to order Crofab for someone in DIC from something else. Good question, though. Pat's asking about fake antivenoms. So the newer freeze-dried ones, you know, there's antivenom. Some of them have to be refrigerated, some don't. In Africa now, there's a new one from Inasan that Jordan and I are very familiar with, called Inaserp or Polyserp or Inasan. And that one is field stable, so we keep it in our backpacks. And you don't need to be refrigerated, which is great, because when we have our snakebite clinic, right, do we have power most of the time? I couldn't even tell. I don't think we did. So these are really good ones. You just have to know which ones, as opposed to the Cymere South African polyvalent, that has to be refrigerated. So good question. What else? You want to jump on any of these?
Yeah, definitely. Casey, are we also, I see you want to pipe in there. Are we good to go? Or
I'm happy for us to answer a few more of these questions. I think
Awesome.
Scroll down. There's a few that are upvoted quite a bit. If you want to try to hit those.
Yeah.
Oh, now I see the
definitely.
thumbs up. Yeah.
Yep. One that I want to hit for sure is antivenom compatible with epinephrine in case of anaphylaxis? And the answer is absolutely. That's actually the only effective pretreatment as well. The 0.5 syndrome, the 3.5 that we talked about, is called sudden collapse. And it's basically patient collapses within 5 to 30 minutes of the bite. Usually altered mental status, systemic bleeding can occur. But if you get someone who looks like they're having anaphylaxis right after the bite, they need epi. They may even need IV epi. They need fluids, and then they need lots of antivenom. So absolutely compatible and best practice for managing that. If it looks like anaphylaxis, treat like it's anaphylaxis and then give antivenom.
Yeah, someone had asked in terms of If you're out hiking, do you decide? It's case by case. If you don't have cell phone signal, can they walk? Absolutely. You don't need to fully immobilize them, but you need to stay calm. And it's not because you're keeping their heart rate down so you stop the spread of venom. It's so you don't make bad decisions. And you, as a nurse out in the wilderness, need to decide, is it safe? Can I get to a collection point? But you don't want to get further lost. So it really just kind of depends.
Yeah.
A lot of people ask about pressure bandage immobilization. The studies for pressure bandage are based on retrospective studies in Australia. Those are like all elapids and Australian ones. You don't use it anywhere else in the world, especially pit vipers and cobras, which are also elapids, because of the effects it's going to do it. So no tourniquet, no pressure bandage mobilization for anything other than considering it in those Australian ones there. And there's actually some decent studies that show that even like elapids, like the coral or a mamba, where they had a tourniquet on, the venom, it didn't stop the progression. It had already gotten into the system enough and they had the paralysis. So it would not have helped in my case in Gainesville.
And in cases where we do see any sort of effect from it, I've actually seen that it makes it much, much worse. So either locally or even with the neurotoxic bite systemically, we'll see that those patients tend to decompensate very, very rapidly after you remove that in a lot of cases. But in some cases, it also does something weird where it could even delay it for hours. And then all of a sudden they just like that will immediately just crump on you and be essentially rapid paralysis and respiratory arrest. So you really have to watch them. We generally say 24 hours of observation is ideal. But just know that your signs and symptoms can manifest in unusual way, timelines, especially with things like tourniquets, but they will always present with at least one or more of the signs of those three main syndromes, and they'll always progressively get worse if it's an envenomation that requires treatment. So it's pretty easy to identify these once you have that tool.
I want to touch for one last question, then I'll, Casey, real quick, when we end this, am I still able to type in the replies to some of these?
I'm fine to stop the recording and let you respond to some. If anyone wants to stick around, I'm okay with like answering a few more of these questions. Absolutely.
Okay, cool. I didn't know how I kind of worked with it. So stick around if you want to answer some more questions. You see our contact info, but I do want to make sure that again, you can reach out to us. And I want to thank the Wilderness Medical Society and of course, Trusted for this opportunity.